Clinically relevant trematodes and nematodes. So starting with the trematodes. Trematodes are also known as flukes. The most common clinically relevant ones are going to be Fasciolopsis buski, Fasciola hepatica, Clinorchus sinensis, Paragonimus westermanni, and Schistosoma species. You should know the common name as well as the scientific name. In general, adult flukes can range in size from a few millimeters to almost 8 centimeters. Except for blood flukes, adult flukes are dorsal-ventrally flattened, have an oral sucker at the anterior end, have a ventral sucker located in the midline, and they're hermaphroditic, possessing male and female reproductive organs. The egg is the primary diagnostic stage. We do a wet mount of fecal concentration to look for the eggs. The typical life cycle, so if we start with the egg, eggs are going to be released into fresh water. Then eggs are going to hatch and become the first larval stage, which is called the myricydia. The myricydia is then going to penetrate into a snail, and the snail is the first intermediate host. Once it leaves the snail, it's going to leave as a cercariae, which is the second larval stage. The cercariae can then enter into either crabs, fish, or vegetation in the water. If certain types of cercariae enter into crabs, they can then, if we ingest them, then we would release Paragonimus westermanni into the body, and eventually the adult worms end up in the lungs. If we ingest undercooked fish or raw fish, then we've got a couple different types of organisms that can end up in the intestine and in the liver. And then if we eat the vegetation, Fasciolopsis buski can end up in the intestine, and Fasciola hepatica can end up in the liver. So this is a picture of all the different types of eggs that we're going to talk about today. And you can see the different structures in the eggs. Now, Fasciola hepatica and Fasciolopsis buski are really difficult to distinguish. Intestinal flukes. So the giant intestinal fluke are common in dogs and pigs. Those are the reservoir hosts. Transmission would be eating metacercaria on raw vegetation, so bamboo shoots, water chestnuts. They live in the duodenum. Symptoms of heavy infections include persistent diarrhea, anorexia, edema, ascites, nausea, vomiting, or intestinal obstruction. And this is a picture of the egg. And these eggs are indistinguishable, so Fasciolopsis buski and Fasciola hepatica are going to look pretty identical. Liver flukes. So the sheep liver fluke causes disease known as liver rot, characterized by liver destruction. Transmission would be eating raw vegetation, especially watercress. Heavily infection symptoms would be diarrhea, upper right quadrant abdominal pain, hepatomegaly, cirrhosis, and liver obstruction, with resulting jaundice. Tissue damage during migration through the liver can result in eosinophilia, inflammatory reaction, secondary bacterial infection, and fibrosis in the biliary ducts. Chronic infections are usually asymptomatic. And then again, that's the same picture as the picture before because these eggs are indistinguishable. Clinorchus sinensis. This is the oriental liver fluke. Transmission would be ingestion of the metacercariae in raw, undercooked, or pickled freshwater fish. Far East, dogs and cats are also reservoir hosts. Symptoms: light infections are usually asymptomatic, but repeated or heavy infections show inflammation, fever, diarrhea, pain, fibrotic changes, or obstruction of the bile ducts. Diagnosis is made by finding ova in the feces or occasionally in duodenal aspirates. So this is a picture of Clinorchus sinensis egg. Here you can see the operculum and the abopercular knob. And this is a much smaller egg, so that's another distinguishing feature of this guy. And here's a few more pictures of it. Lung flukes. Paragonimus westermanni. Primarily found in Southeast Asia, focal areas of Latin America and Africa. It's the oriental lung fluke. Transmission would be eating raw, undercooked, or pickled freshwater crabs or crayfish. Major symptoms associated with lung habitation. Nonspecific often include persistent cough, chest pain, and hemoptysis. This is a picture of the egg, and here is a larger picture of the egg. So you can see the size difference between Clonorchis sinensis and Paragonimus westermanni. You can also see that Clonorchis sinensis has this apopercular knob sticking out here. Blood flukes. So schistosoma species, causative agent of schistosomiasis, different from other flukes. There's a separate male and female adult. Other flukes are hermaphroditic. Eggs are unoperculated. Infection by direct cercarial penetration of the skin. So these guys go right through your skin. You don't necessarily have to eat anything in order to come in contact with them. Cylindrical shape rather than being dorsoventrally flattened. 3 primary species: Schistosoma mansoni, Hematobium, and Japonicum. The location, Schistosoma mansoni, would be found in the venules of the mesentery and large intestines. Schistosoma japonicum would be found in the venules of the small intestine. And Schistosoma hematobium would be the veins surrounding the bladder. Schistosomiasis affects approximately 200 million people worldwide. Symptoms are related to the phases of the fluke's life cycle and the location of the adult worm. Cercarial penetration may cause self-limiting local dermatitis. It persists for approximately 3 days, and you have irritation, redness, and rash. So basically, these guys are spread through the snail. The snail is the intermediate host. So if you go wading in snail-infested water in the regions where these are common, what can happen is the larvae will leave the snail and then they burrow through your skin. And from there, they travel to the various locations of the body. So depending on what type it is, that depends on where it's going to end up in the body. Now, when it initially penetrates through the skin, it's going to cause a local rash. It's going to look like just little raised bumps, and it's going to look like local inflammation, a little bit of redness, and then like red bumps that are raised. The rash is going to go away after about 3 days, and you're going to have pretty much no symptoms. But secretly, these things are burrowing inside of your body. So during larval migration, there's generalized symptoms. Urticaria, fever, malaise can last up to 4 weeks. The presence of the migrating larvae in adults in the veins cause little inflammatory damage, seemingly because they acquire hosts' HLAs and ABO blood group antigens on their surface that diminish the host's response. So while these guys are migrating through your bloodstream, they're actually taking your own blood proteins and coating them on their backs so that they can go undetected. Egg production and egg migration through the tissues are responsible for most of the immediate damage because the eggs are highly immunogenic. After the eggs are released by the adult female, eggs secrete enzymes and begin to penetrate the vessel walls and tissue. Eggs subsequently find their way into the lumen of the intestines or bladder. The egg spines cause trauma to the tissues in the walls of the vessels during the early stage of acute infections and can result in gross or microscopic hematuria, so blood in the urine, or diarrhea for the S. mansoni and Japonicum species. Those heavily infected with S. japonicum experience an acute serum sickness-like illness, Katayama fever during the initial egg-laying period, induced by antigenic response to the egg, characterized by increased circulating levels of immune complexes and eosinophils. Chronic infections, eggs remaining in the tissue induced immune response resulting in granuloma formation, thickening and fibrotic changes, scarring of the veins, development of ascites, pain, edema, or anemia, hypertension, hepatomegaly, and splenomegaly are also seen. Urinary schistosomiasis, acute phase bleeding, chronic stages, dysuria, urine retention, and UTIs. Penetration of humans by cercariae of the flukes of birds and other mammals causes schistosomal dermatitis, commonly referred to as swimmer's itch. So related species cause swimmer's itch. Foreign proteins from these cercariae elicit a tissue reaction. It's characterized by small papules 3 to 5 millimeters in diameter, edema, erythema, and intense itching. Symptoms last about a week and disappear as the cercariae die and degenerate. So they don't actually cause a prolonged infection when you get swimmer's itch. So here's the life cycle of blood flukes. So you've got eggs that passed out in the urine or in the feces. Then they go in fresh water. And then they're going to hatch and become Miracidae, which then penetrate into the snail. From the snail, they leave, becoming cercariae, and then they can penetrate into the host. Once they penetrate into the host, so if it goes through your skin while you're wading in snail-infested waters, it's then going to hit circulation and target particular areas depending on what type it is. So Schistosoma hematobium is going to go to the veins of the bladder, Schistosoma mansoni is going to migrate to the veins of the large colon, and Schistosoma japonicum is going to migrate to the small intestine. Then you'll have adults in the specific organs and where they implanted. Diagnosis: finding embryonated eggs in the feces, eggs or in the urine if we're talking about hematobium. Eggs are oval-shaped with spines located on the eggs. S. mansoni, embryonated, found in feces, prominent lateral spine clearly visible, and no operculum. S. hematobium is found in the urine, terminal spine is clearly visible, and no operculum. S. japonicum, found in feces, small, curved, often obscure, rudimentary spine, and no operculum. Best time to collect eggs in urinary schistosomiasis is during peak excretion time in the early afternoon, noon to 2 p.m. Biopsy may also be used in the diagnosis of schistosomiasis. Serodiagnosis can be useful to diagnose infection in patients from non-endemic countries who develop symptoms after visiting endemic areas. In areas of endemicity, serum antibody testing cannot differentiate between active and non-active infections. A urine-based rapid test strip for the detection of parasite antigen is commercially available and useful in field screening. So this is a picture of Schistosoma mansoni egg. This one is clearly distinguishable because of this hook that comes out on the side here. So it's an oval-shaped egg that almost comes to a little bit of a point at the end, and then it has this sharp hook that hangs off to the side. This is a picture of Schistosoma japonicum. This one is almost circular with some ripples along the edges. And some more pictures of Schistosoma japonicum. You do see these inconspicuous spines that kind of stick out on the sides here, and they are pretty circular. Schistosoma hematobium, here you can see they're in the bladder tissue, but you can see they're elongated with these spines that stick out in the middle. And here is another picture of Schistosoma hematobium. So unlike Schistosoma mansoni that had the spine out the side, Schistosoma hematobium is going to have this spine directly in the middle here. So that sticks out like that. And putting them all together, Schistosoma japonicum, circular, has this little tiny spine sticking out the side. Schistosoma hematobium is elongated with the central spine. And then Schistosoma mansoni has the spine sticking out of the side. And here they all are together. And then we go from here and we have a comparison of all of the Schistosoma species. We have Japonicum, Mansoni, Hematobium. Then we have Paragonymous westermanni. Fasciola hepatica and Bouskai are pretty much indistinguishable, so we wouldn't be able to tell those apart. Clinorchus sinensis is right here. And then these guys, although they are significant, we are not going to cover them in this lecture series. So moving on to the nematodes, or the roundworms. The common and scientific names for our key players here are listed here. So Enterobius vermicularis, Trichuris trichuria, Ascaris lumbricoides, Necator americanus, and Ancylostoma duodenale, and Strongyloides stercorolus. Human roundworms include those that infect the intestinal tract, blood, and tissues. They're distributed worldwide, most common of the helminths to cause human infections in the United States. Modes of transmission: ingestion of an embryonated egg, direct penetration of the skin by larvae in the soil, or by an insect vector. Roundworms are characterized by the presence of two sexes and a life cycle that may involve larval migration through the body. Adult worms obtain nourishment by absorbing nutrients from partially digested intestinal contents or by sucking blood. Patients may be asymptomatic or symptomatic. The severity of symptoms is related to the worm burden, so how many worms are found inside the body, host nutritional status and age, and duration of the infection. Most roundworm infections can be treated with oral administration of albendazole or mebendazole. Here's some pictures, some cartoon drawings of our key players. Enterobius vermicularis, so this is known as the pinworm, causes pinworm infection. It's common in children 5 to 10 years old. Key risk factors would be inadequate personal hygiene or inadequate community hygiene. Populations at risk, families, kindergartens, daycare centers, crowded conditions. Egg characteristics, they are resistant to drying and they easily spread in the environment because they're so small. So areas where adult worms may be found, they live in the large intestine, occasionally found in the appendix or the vagina. Possible outcomes of ectopic infections, endometriosis, urethritis, salpingitis. There is evidence that the pinworm is associated with UTIs in young girls. Often asymptomatic, but if they do become symptomatic, loss of appetite, abdominal pain, loss of sleep, nausea, vomiting, anal pruritus caused by the migration of the female adult worm through the anus at night to lay eggs in the perineal area. So the life cycle. We start with the eggs. Typically, the eggs are inhaled and then ingested. So they're breathed in and then they kind of go down into the throat, into the digestive tract. From there, we are going to release larvae. The larvae grow into adult worms, and then the worms will migrate out of the anus at night. Typically, we have a male and female worm that kind of hang out inside of the rectum. And then at nighttime, the female will poke her head out and deposit eggs on the surface of the anus. And then when the child scratches, because these eggs cause a lot of local inflammation, when the child scratches that area, then they can spread it that way. They can give it to all their friends if they don't wash their hands. Or the eggs actually get deposited in their sheets at night, so when they get up in the morning and they fan their sheets out, those eggs basically spread around the entire house. And then mom or dad come by and breathe in, or brother and sister come by and breathe in those eggs and kind of all get infected. So typically if one person in the household is infected, the rest of the household becomes infected very quickly. Laboratory diagnosis would be the cellophane tape preparation, and there's commercially available sticky paddles. Basically, you would tape the child's butt while they're sleeping, and then the female would come out at night while the anus is a little bit relaxed because the person's asleep, and she deposits the eggs, and the tape would get those eggs. And then you just peel off the tape in the morning, and then you would look at the eggs under a microscope to identify. Because the gravid female can migrate into the vagina, eggs can also be seen in vaginal specimens. This is a picture of an egg, and then several more pictures for you to review. Here you can see a picture of the male and female worm. You do not need to identify the worm, just the egg from pictures. It is important to note that the female is much larger than the male worm. Trichuris trichuria, so soil transmitted, along with 2 species of hookworm and ascaris. Strongyloides stercoralis is another one that's soil transmitted. Worldwide distribution, and they're a major cause of morbidity rather than death in developing areas of the world. It's estimated that 25% of the world's population is infected with one or more of these organisms. So Trichuris trichuria is also known as the whipworm, and that's the causative agent of trichuriasis. Moist, warm climates are the environment of choice. Often presents as a co-infection with ascaris. Chronic infection can adversely affect physical and mental development in children. Heavy worm burden likely to result in complications. Risk factors: poor sanitation, poverty, occupation, climate. Light infections are usually asymptomatic, but heavy infections result in colitis or diarrhea with blood-tinged stools. Rectal prolapse can be the result of repeated heavy infections in undernourished children. In children with inadequate iron and protein intake, the presence of constant low-level bleeding with chronic infection can lead to hypochromic anemia. Treatment would be mebendazole or albendazole. Life cycle notes: the eggs are passed in the stool. They require at least 14 days in warm, moist soil for embryonation to occur. Humans ingest the infective egg, larvae is released in the small intestine, undergoes several molts before maturing, and then the adult worm emerges in the cecum. Diagnosis: eggs and less commonly adult males in the stool. So this is a picture of the egg. It is a very distinguishable egg because you've got these knobs on each end. There's no other egg that looks quite like this. It's kind of like a football shape with these two knobs on the ends. And here's a picture of it in a specimen that I identified. And then you can see the mucus plugs on the outsides. And here's several more pictures of this egg. And here's a picture of a male and female whipworm. So this is why it's called a whipworm, because one end looks like the end of a whip and then it looks like a handle here. You do not need to be able to identify the worm itself, just the eggs. Ascaris lumbricoides, so more than 1 billion people are infected worldwide. It's most common in tropical and subtropical areas and in areas of poor sanitation. It's uncommon in the United States, but seen in rural parts of the southeast. Mode of transmission: fecal-oral route, often found concurrently with whipworm. It's known as the intestinal roundworm. It's a causative agent of ascariasis. Clinical symptoms may be related to the different phases of the life cycle. Symptoms when the adult worms are in the intestine are abdominal discomfort, loss of appetite, and colicky pains. Heavy infections are thought to contribute to lactose intolerance and malabsorption of some vitamins. In children, large numbers of adult worms can cause intestinal obstruction. Because the worms feed on liquid intestinal contents, chronic infection with A. lumbricoides may hamper growth and development. Larval migration through the lungs can cause an immune response in the host, such as asthma, edema, pneumonitis, eosinophilic infiltrations, rarely larvae seen in the sputum in heavy infections. Occasionally, fever or other disease conditions cause the adult worms to migrate from the intestine and invade other organs, resulting in peritonitis, liver abscess, or secondary infection in the lungs. Adults may also exit through the mouth, tear duct, or nose, and they have been reported to enter and block catheters. Eosinophilia may be present. Albendazole or mebendazole are the drugs of choice. So here is the life cycle. So you've got the eggs are going to mature in the soil, then the human ingests the eggs, and then they are released into the intestine. When they hatch, the larvae are going to then penetrate through the intestinal wall, and they travel through, they don't penetrate the intestinal wall quite yet. They're going to hatch, and then they migrate up and into the lungs. Then from the lungs, they are going to mature into adult worms, and then eventually they travel back up the throat and then get swallowed back down into the intestine. So it does this whole like gross lung thing. It was in the intestine, it left the intestine, and then it went into your lungs, and now it came back from the lungs, and now it's back in your intestine. And that's where the worms are going to stay. The usual diagnostic stage is the egg. Fertile egg morphology is listed. Most eggs have a brown bile-stained mammalian outer layer. So this is a picture of an Ascaris fertile egg. You can see it's pretty round, and then it has these ridges on the outside. Here's some more pictures. So this is from an actual prepared slide. And then here's kind of a cartoon drawing of the egg. This is the unfertilized egg, and what that would look like. And then when it's fertilized, this is what it would look like. So the fertilized egg is the infective stage. And then this is a picture of what the worms actually look like. And moving on to the hookworm. So worldwide, about 740 million people are estimated to be infected with hookworms. Greatest incidence tropics, subtropics, Latin America, the Caribbean, sub-Saharan Africa. In the United States, hookworm infection was common in the 1950s. Improved sanitation greatly reduced the incidence. It's the causative agent of hookworm infection. Unlike other helminths, the hookworm burden often increases with age. There are two main species of hookworm associated with human infection: Ancylostoma duodenale, which is the Old World hookworm, and Necator americanus, which is the New World hookworm. Geographic distribution: Ancylostoma duodenale, southern Europe and northern Africa, along the Mediterranean, parts of Southeast Asia and South America. Necator americanus, Africa, Southeast Asia, South and Central America, endemic in rural areas of southeastern United States. Ancylostoma sciancium is an animal parasite that's prevalent in Southeast Asia, Australia, and the Pacific Islands, and it was recognized as a human pathogen. Adult worms of the three hookworm species can be differentiated by the buccal cavity, but the eggs are identical. So the life cycle: the eggs are in the feces, they would then mature in the soil, a rhabditiform larvae would emerge, and then they would go through and penetrate through the skin as someone is walking through infected soil. The larvae then is going to migrate up to the lungs, where it's going to then migrate up the trachea over the epiglottis and get swallowed down into the intestines. And then it's going to mature into an adult worm in the intestine, and those adult worms are then going to release more eggs into the feces. Clinical symptoms differ according to the phase of the life cycle and the worm burden. A small red itchy papule formed as a ground itch developed at the site of larval penetration. If large numbers of larvae are present during the lung phase of migration, the patient may have bronchitis, or no host sensitization occurs. Most severe symptoms associated with the adult worm. Nonspecific symptoms would be diarrhea, fever, nausea, vomiting. Eosinophilia is often present. A few patients may experience pica and then ingest dirt, geophagia. Blood loss ranges from 0.03 to 0.2 mils per worm per day, primarily the result of the ingestion of blood by the adult worm. Hemorrhages at the attachment site can also contribute to total blood loss. In chronic heavy infections, it can lead to hypochromic anemia, especially in malnourished children. May affect the mental and physical development of child because of the anemia and malnutrition. Infection is usually treated with the same drugs we've been talking about for roundworms. So we've got albendazole or mebendazole. Supportive therapy, iron and protein supplements may be needed in severe cases, especially if the child shows evidence of anemia. If the infection occurs in pregnant women, vaccine development, or they would need additional supportive therapy. Vaccine development using hookworm antigens is being targeted as a way to help control infections. This is what the egg looks like. So you could see this large oval shaped with all of these circular shapes on the inside. 4 to 8 cell stage of cleavage. So here's a picture of the egg in a prepared specimen. Here is the cartoon drawing of that egg. And here's some additional drawings of, or pictures of the egg. Distinguishing features in adult worms, rarely seen in stool specimens: the anterior buccal capsules. N. americanus has a flat tetrad cutting plates. A. duodenale has 4 pointed teeth. The rhabditiform larvae, non-infective feeding stage, the larvae of the three species are indistinguishable. So that's what the rhabditiform larvae look like. The filariform larvae are the infective stage. Those are the ones that can burrow through your skin. The hookworm larvae must be distinguished from that of S. stercoralis to diagnose. So we go through, and this even has some of the tapeworm eggs that we talked about previously, but this is a really good differentiating chart that shows you the different eggs of many of the different species that we talked about, and a few that we didn't talk about. And here's another differentiating chart. All right, Strongyloides torcoralis. This is known as the threadworm. It inhabits the small intestine but is also capable of existing as a free-living worm. Endemic in the tropics and subtropics, Southeast Asia, Latin America, Sub-Saharan Africa, found in all continents except Antarctica. It's estimated that 30 million to 100 million people are infected worldwide. Patients may be asymptomatic, but when they're symptomatic, fever, nausea, vomiting, tracheal irritation, sharp stabbing pains that resemble those of an ulcer or other GI disease, including pancreatitis. Eosinophil count is often elevated. Larval penetration does not cause a prominent papule. Migration through the lungs rarely elicits pneumonitis. Patient may have wheezing and a mild cough. The mortality rate in immunocompromised patients is over 80%. The usual causes of death are complications resulting in respiratory failure. Disseminated strongyloidiasis, however, is not common in patients with advanced age, despite their immunocompromised status. Okay, so a couple different pathways that this guy can take. We're going to first talk about the rhabditiform larvae in feces. You can get an autoinfection. The filariform larvae develop in the intestine. They penetrate the intestinal wall, enter into circulation, and break through the alveoli. From there, they can migrate to the trachea and then are eventually swallowed. And they complete their development in the intestine. If feces are deposited in the soil, you can do the direct route, where the filariform larvae develop in the soil and then enter in through the skin and enter circulation that way, or the free living cycle, where free living male and female adult development, egg production, hatching of rhabditiform larvae, and then they eventually go into the filariform larvae. Adult female is rarely seen in stool samples, and no male has been identified in intestinal infections. So the primary diagnostic stage in humans is the rhabditiform larvae. And this is a picture of that larvae. And here's some more pictures of it. And here's some more pictures that you can take a look at. Filariform larvae may be found in patients with hyperinfection. Sputum specimens inoculated onto sheep blood agar after 24-hour incubation with 5% carbon dioxide in the air reveal heavy bacterial growth in the area of primary inoculation. Thin trails of colonies lacing the surface of the agar due to the moda larvae. So these guys we can detect in sputum specimens. And this is a sheep blood agar plate inoculated with expectorated sputum. Diagnosis relies on identification of larvae in the stool. If the clinical symptoms suggest strongyloides infection but multiple stool samples test negative for the larvae, a duodenal aspirate or biopsy may be used for diagnosis. The organisms live in the upper small intestine. No specific antigen tests are available, and antibody tests can't distinguish current from past infection. They're also prone to false positive results with infections from other helminths. Recommended therapy, ivermectin with albendazole is an alternative. In hyperinfection or disseminated infections, it's recommended that immunosuppressive therapy may be reduced if possible. Blood and tissue roundworm infections. Trichinella spiralis, causative agent of trichinosis, infection of muscle tissue with the larvae of T. spiralis. Adult stages live in the human intestine. Mode of transmission, consuming contaminated undercooked meat, particularly pork. Life cycle notes, after ingestion, the larvae are released from the tissue capsule in the intestine. Larvae mature into adults in the intestine. Female worms produce live-born larvae. Live-born larvae penetrate the intestinal wall, enter circulation, and are carried through the body. Live-born larvae enter striated muscle and begin the maturation cycle that is complete in about 1 month. Live-born larvae coil and become encapsulated, remaining viable for years. Eventually, capsules calcify and the live-born larvae die. Few symptoms occur during the intestinal phase, diarrhea, abdominal discomfort, but most symptoms occur during the migration and encapsulation periods. The severity of symptoms depends on the number of parasites, the tissue invaded, and person's general health. Symptoms that occur during the larval phase are the result of an intense inflammatory response by the host. Common symptoms include periorbital edema, fever, muscular pain and tenderness, headache, and general weakness. Muscle enzyme levels may be elevated. Splinter hemorrhages beneath the nails can be seen in many patients. Increase in eosinophils is common. Patients with symptoms should be treated with analgesics and general supportive measures. Steroids are only given in rare cases. The use of albendazole or mebendazole is effective when administered early in the infection before the release of the larvae. If diagnosis is delayed, the impact of the antiparasitic drug is less effective. It's difficult to recover adults or larvae in the stool. This diagnosis is based on clinical symptoms and the patient's history. Biopsy of muscle tissue and identification of encapsulated coiled larvae is the definitive diagnostic method. The presence of calcified larvae on radiographic film indicates an infection. Serological tests are available. So this is that picture of that in the muscle tissue. You can see it here centrally. And then here's a few more pictures. And here's a really cool picture where it's kind of coiled up. Here's another picture. And here are some more pictures encapsulated inside the muscle tissue. Larval migrans. So there's two forms of larval migrans in humans, cutaneous and visceral. Humans are the accidental hosts for non-human nematode larvae in both cases. In the United States, cutaneous larval migrans occurs primarily in the southwest mid-Atlantic and Gulf Coast areas, most commonly caused by the falciform larvae of the cat or dog, hookworm, Ancylostoma brasiliense. Cutaneous larvae migrans life cycle notes. The larvae penetrates the skin through a hair follicle, a break in the skin, or unbroken skin. Once inside the body, the larvae wanders through the subcutaneous tissue, creating long, winding tunnels. Secretions from the larvae create a severe allergic reaction with intensely itching skin lesions that are vesicular and erythematous. Secondary bacterial infections can result from scratching. The infection resolves within several weeks when the larvae dies. Diagnosis is based primarily on history and clinical symptoms. Visceral larval migrans. Humans accidentally ingest the eggs of the dog roundworm, Toxocara canis, or the cat roundworm, Toxocara cati. Larvae hatch into the intestine, penetrate the intestinal mucosa, and wander through the abdominal cavity. Larvae can enter the lung, eye, liver, or brain. The infection is seen primarily in children ages 1 to 4. Clinical symptoms: malaise, fever, pneumonitis, hepatomegaly, increase in eosinophils. CNS complications may develop. Eye invasion, also known as ocular larvae migrans, eosinophilia is absent. Diagnosis is made on the basis of clinical findings and results of serological tests using Toxocara-specific antigens. Filarial worms. So Wuchereria bancrofti, Berrugia malayi, Loa loa, and Onchocerca volvulus are the four main ones that we're going to discuss. Mancinella is usually not associated with serious infections, and Dranculus can cause serious infections in certain parts of the world. We just don't usually cover that one. So the filarial worms are roundworms of blood and tissue. They're found primarily in tropical areas of the world. At least 8 species infect humans. Most pathogenic are the 4 that I mentioned. Lymphatic filariasis caused by W. bancrofti, B. malayi, and B. timori, second most common mosquito-borne illness after malaria. Adult filarial worms give birth to live-born larvae referred to as microfilariae. Identification depends on the morphology, periodicity, and the location of the worms in the host. Microfilariae morphology, characteristics used in identification: presence or absence of a sheath, the arrangement of nuclei in and near the tail, and some microfilariae migrate to the blood during certain times of the day or night, periodicity. Adult filarial morphology range in size to from 2 to 50 centimeters. They live in lymphatics, muscles, or connective tissue. Mature females produce microfilariae, larval infective stage. So here's a picture of the four main ones are here, and then you can see their tail morphology and then what they would look like, so you can be able to start to distinguish them. So Wucheria bancrofti and Brugia malayi are transmitted by the mosquito, while Loa loa and Onchocerca volvulus are transmitted by the fly. These two infect the lymphatics, causing elephantiasis. So elephantiasis is when you get that roundworm stuck in your lymphatic vessels and it causes edema, while these two are more in subcutaneous tissue. All right, so we have the live microfilariae. They get into the bloodstream by and then a mosquito is going to, the biting of the human and ingestion of malaria by the, or microfilariae by the insect. Microfilariae develop in the insect, and then they migrate into the insect salivary gland, and then when the insect bites again, they will migrate and the adult worms go to their respective tissues. Wucheria bancrofti, causative agent of Bancroftian filariasis. Adult worms live in the lymphatics and lymph nodes, especially in the lower extremities. The presence of the adults initiates an immunologic response consisting of cellular reactions, edema, and hyperplasia. A strong granulomatous reaction with production of fibrous tissue around the dead worms ensues. The resulting reaction causes the small lymphatics to become narrowed or closed, causing an increase in hydrostatic pressure, with subsequent leakage of fluid into the surrounding tissue. During this time, the patient may experience generalized symptoms, fever, headache, chills, localized swelling, redness, lymphangitis. The affected sites in the male and female genitalia extremities. Elephantiasis is debilitating and deforming complication, occurs in less than 10% of infections, usually after many years of continual filarial infection. Chronic obstruction to the lymphatic flow results in lymphatic varices, fibrosis, and proliferation of dermal and connective tissue. The enlarged areas eventually develop a hard, leathery appearance. Diagnosis: examination of a blood specimen obtained at night for the presence of microfilariae. Blood specimens may be examined immediately for live microfilariae or may be pooled in on a slide and stained. Filtration of up to 5 ml of blood through 5 micrometer nucleopore filter can detect light infections. So it's sheathed. Nuclei do not extend to the tip of the tail. 3 antigen detections assays are available, but none have U.S. FDA approval. No antibody detection tests are available. So you have to actually find the microfilariae in the blood. Brugia malayi. Geographic distribution limited to the Far East, including Korea, China, and the Philippines. The genre Mansonia and Aedes mosquitoes transmit the organism. The pathologic aspects of the disease and clinical symptoms are the same as those seen with W. bancrofti. They do have a sheath, and the arrangement of the tail nuclei. The nuclei extend to the tip, but a space separates the two terminal nuclei. Loa loa, known as the African eyeworm, causative agent of loisis, geographic distribution limited to African equatorial rainforests where the fly vector breeds. Adult worms may live in humans for as long as 15 years. They migrate through subcutaneous tissue, causing temporary inflammation reactions called calabar swellings. Calabar swellings can cause pain and pruritus that lasts about a week before disappearing, reappearing in another part of the body. The adult worm can often be seen as it migrates across the surface of the eye. Diagnosis is based on the presence of calabar swellings of the adult worm in the conjunctiva of the eye. Microfilariae may be in a blood specimen if it's taken during the day, especially around noon when migration peaks. The microfilaria is sheathed and nuclei extend to the tip of the tail. Onchocerca volvulus, the causative agent for onchocercosis, also known as river blindness. Geographic distribution, Africa and South and Central America. Mode of transmission, bite of the black fly. Adult worms are encapsulated in fibrous tumors and subcutaneous tissues of humans. Microfilaria can be isolated from the subcutaneous tissue, skin, the nodule itself, rarely found in blood or lymphatic fluid. The nodules in which the adult lives may measure 25 millimeters, can be found in most parts of the body, a result with an inflammatory and granulomatous infection around the adult worms. The most serious complication is blindness, which results when microfilaria collect in the cornea and iris, causing hemorrhage, keratitis, and atrophy of the iris. The presence of endosymbiotic bacteria in the genus Wolbachia has been linked to simultaneous stimulation of the host immune response and may contribute to the inflammatory tissue reaction. Diagnosis, clinical symptoms, presence of nodules, microscopic identification of microfilariae. Diagnostic method used to isolate microfilariae would be the skin snip, a process which a small slice of skin is obtained and placed on a saline mount. The skin snips then pose a risk of infection. Microfilariae with no sheath, with nuclei that do not extend to the tip of the tail, are characteristics of Onchocerca. Gnats are being used in research laboratories. Serological assays using recombinant antigens have demonstrated high sensitivity and specificity. So this is a picture of tissue infected with it. Here's a picture of Wuchereria bancrofti. Here's some more pictures of Wuchereria. Here's Onchocerca volvulus, Loa loa. Here's more Loa loa. Brugia malayi. Here's some more Brugia malayi. And then here are some major differentiating features. So 1, 2, and 3 are usually found in the blood. So here you can see some key differences, so you can kind of pause the video and review these. And then here are diagrams of the major differences.